Welcome everyone to the May 3rd Friday Addiction Toxicology Conference. Thank you all for joining. I'm going to unmute Stephanie, or Tricia, if you could unmute Stephanie. That's actually, I can do that. Stephanie, how you doing?
Yep, I'm here. Can you hear me? Can you hear me?
Yes, perfect. We've got several
Fantastic.
really good cases today, and Stephanie Weiss, MD, PhD, Senior Fellow at UT Southwestern Parkland, is going to be presenting the first case. So just let me know when you want to advance the slides, and I'll do so. Just anyone that, when we break for comments or questions, just raise your hand, or you can also send a chat question or comments, and we'll read those as well. And we will start our conference. Thank you. Go ahead, Stephanie.
Great. Thank you very much. So I wanted to present to you guys a case that we got consulted for on the toxicology service here earlier this year. And this was specifically at our university hospital, where they have a pretty good-sized transplant group and transplant program, and they had a patient there that they were working up for a potential transplant. Can you please advance to the next slide? So this gentleman was 38 years old, and he'd been in the hospital for about 3 weeks by the time that we were consulted. And he'd been admitted 3 weeks prior for hepatic encephalopathy. So he had a pretty extensive history of liver disease, and this was due to him having had a history of alcohol abuse disorder, although he reported that he had been sober for 10 years, and his wife did confirm that. But he did have cirrhosis, and that was why he was in this program being evaluated for a potential liver transplant. And he had some other significant medical issues as well. He had a history of heart failure. He had VTAC and had been ablated and had an AICD placed. He had diabetes and he was insulin dependent. He had chronic kidney disease. So despite his young age, he actually had quite a number of serious issues going on medically wise. Can you please advance to the next slide? Okay, so the reason why we got involved is because the transplant team, as part of their workup to consider him for whether he would be eligible for a transplant, they had given him a urine drug screen. And in fact, he'd had two since he'd been in our hospital. The first one was on admission 3 weeks prior, and it was positive for amphetamines. And then he had another one the day before we were called, so 3 weeks subsequently, that was again positive. And the patient, he wasn't 100% able to give a lot of history just because, like I said, he was there for encephalopathy and he still had some elements of encephalopathy, but his wife was there, and both of them were saying, he does not use any drugs. And the transplant team, of course, is understandably a bit skeptical, because the reason why he was requiring a transplant in the first place is because he has this history of abuse. And so the problem here is that he could not be listed if he was using drugs. And they had actually done a fair amount of attempting to figure out why he was getting this positive result. They had gone through his medication list. There was nothing on there that he had received while he was in the hospital that they could figure out would be causing this cross-reactivity. And that was when they went ahead and called us. And can you please advance? So I just wanted to show you, this is the package insert from the lab that shows all the potential things that have been tested for our assay about that can potentially cause cross-reactivity with amphetamine. And so, like I said, these hepatologists and transplant physicians had done some due diligence. They had actually called the lab and spoken to the technician and said, listen, this guy keeps coming up positive for amphetamines. He swears he doesn't take them. They went through his medication list, and nothing was there on these lists. So you can see there's a pretty extensive list of things that have some cross-reactivity with the test and are known to. And the lab tech had gone through the list with them and could not find anything from his medication list that was known to be cross-reactive with our assay. Can I get the next slide, please? So their question for us was, what other thing could we potentially be missing here? Why is this guy still testing positive? Because unless somebody is slipping him amphetamines, he's been in the hospital for the past 3 weeks. Unless somebody is somehow sneaking him amphetamines or something that crosses react with amphetamines, he shouldn't be having a positive test still.
That's great. Thank you. If you have any questions or thoughts on this, please raise your hand and I will unmute you and we can have some discussion. Let's see. Otherwise, I will call on some of you. How about, does anyone from UC Davis want to comment? And we've got a comment from Emory as well. The question from Emory before we get a comment, is this the assay? Can you describe the amphetamine assay? Is this just a immunoassay, or was it confirmed? What type of testing was done?
Yeah, that's a fair question. I didn't explicitly say. It was the urine drug screen, so it is an immunoassay. They had not done conformational testing. And we actually do not have the ability to do that in-house at the Clements Hospital, which is the university hospital here. That is a send out for that hospital.
So that was brought up by several individuals commenting on it would be useful to know if this was an immunoassay or GCMS and if confirmation was not done. So I find it interesting that the hepatology for listing for transplant wouldn't just by procedure confirm a positive result before making any presumptions.
Right. Yeah, I'm not really sure why if they didn't notice then for confirmation, but they had not done a confirmation and had not done a send out.
Just want to clarify these. Instead of getting a hand, I'm getting explanation points, so that may be the actual hands. Is Josh King, do you have a comment? About someone from UC Davis, any thoughts on what this might be, what might be causing the positive immunoassay? Go ahead.
We were thinking, obviously what type of assay was it? Is the patient getting any other herbals or supplements? And what was the actual med list? So maybe there's something that is like a prodrug for something else?
That's a great thought.
Yeah,
Stephanie, go ahead.
Yeah, so as far as I know, he was not on any herbals or supplements that the wife reported to me. And as I said, he'd been in the hospital for 3 weeks, so he definitely had not been taking them while he'd been in the hospital. I do have the med list, which I'm about to show you as soon as this discussion is over.
Have you had a positive amphetamine from an herbal product? Can you describe what that would have been? I can think of a couple historically that may have had triggered the assay.
I was thinking something like cot, because when I think of amphetamines, I think of bupropion, and then I go back to synthetics, and then I go back to cot. So that's kind of how my mind goes backwards.
Good. That's a good thought. I think the herbal ephedra, which hasn't been available for a while, used to be available, and there's been supplements depending on when they've been purchased through things like GNC that have had amphetamine-based type of chemicals that could potentially trigger. There's hexanamine. I don't believe that should, sometimes sold as geranium, I don't believe that should trigger the amphetamine positive. It may. And then there's been some other things that have been in there. The package insert listed some illicit drugs, but it wasn't certainly a comprehensive list. Dr. Bishevitz, do you have any thoughts?
Just that I've read recently that ephedra is sometimes found as a contaminant in herbal products, especially imported herbal products.
Yeah, that's a good thought as well. That's interesting. So again, raise your hand if you have any other thoughts or comments. Does anyone from Syracuse have any ideas? I've just unmuted you. No one from Syracuse, okay. All right, well, I think we've had a couple of ideas. Let's should I move on to the next slide, Stephanie?
Yeah, if you would go to the next one for me. Okay, so here is his medication list. And you can see, like I mentioned, this gentleman, despite his young age, had quite a few medical issues going on. And so he was on aspirin for his cardiac history and carvedilol and several other medications as well. He was on insulin. He was on several medications for his liver disease. And then the one that I've circled there, the mexiletine, this was another one of his cardiac medications that, if you recall back from a couple of slides ago when I showed you the package insert from our immunoassay from the lab there, was not actually listed. And so when the hepatologist called the lab to ask, could any of these medications on this list potentially be cross-reacting with your immunoassay, the lab tech looked through this lab insert, didn't see any of these drugs listed here on the list, and said, no, none of these are listed as being potential cross-reactants. As it turns out, though, the mexiletine is known to be cross-reacting with immunoassays for amphetamines. Can I get the next slide, please? So here you can see I've put the structures, all these compounds here that are amphetamines and amphetamine-based products all have phenethylamine backbones. You see the phenethylamine at the top left there and the amphetamine next to it. Underneath that is the methamphetamine, and then next to it I have the mexiletine. And so you can see the mexiletine is actually pretty similar in structure to the amphetamine, only instead of being a phenethylamine, it's actually an ether derivative, like a phenol derivative, but otherwise it's pretty similar in structure to amphetamine, and it's similar enough that it does cross-react on multiple assays, and there's actually been publications on this. Can I get the next slide, please? And just to remind everybody, because I can't say it, so I was an emergency physician full-time for 3 years before I came for fellowship, and I've continued to work part-time, and I have never once prescribed mexiletine for anyone. So I can't say I'm surprised that these hepatologists had not either, and we're not familiar with this drug. It's a class 1B antiarrhythmic. So remember, these are sodium channel blockers, but these particular subclass, they're the ones that have a high affinity for open or inactivated sodium channels, and they have rapid unbinding during diastole. So they really don't affect QRS as much compared to the 1Cs, for example, and the 1As. Can I get the next slide, please? Here you see the results of his testing. So at the top there, you see from the urine drug screen that he was positive for amphetamines, and they do use the 1,000 nanogram per milliliter cutoff at this lab. Underneath there, we did send it for confirmatory testing. As I said, this had not been done, and so we were able to rule out that he had used any sort of illicit amphetamines that they were concerned about, like the methamphetamine or MDMA. Can I get the next slide, please? And so I just wanted to point out this article at the bottom by Snozek et al. So this is a group of clinical chemists from Mayo, and they put out a paper, it's now been about a year, it was in May of last year, where what they did was check 4 different immunoassays, and they took spiked urine that they had put mexiletine in and were able to show that it was a positive on that. And then also they ran confirmatory testing that was negative for methamphetamine or amphetamine. And vice versa. They had urine from patients that they knew were taking mexiletine, and they tested that as well. And again, we're able to show in both ways. So all 4 of the assays that they checked actually did test positive on the urine drug screen, even though the confirmatory testing for all 4 of them was negative. And it's interestingly, almost as if they had anticipated a case like this, they quoted in their paper, a patient being evaluated for organ transplantation might be questioned or worse, deferred from listing based on an unexpectedly positive UDS result. So it is known that mexiletine can have this cross-reactivity, and I'm not sure why it wasn't specifically in the package insert, which I assume is just because mexiletine is not that commonly used of a drug, but it has been published, and there are other reports in the literature besides this one that confirm that this cross-reactivity occurs.
That's a really interesting case. Thank you. It is interesting that they wouldn't just by due procedure move on to the confirmation. So you had suggested the confirmation, or the toxicology consult service had suggested the confirmation?
Yes.
It wouldn't have been
we were the consult service. That was us. We were the toxicology consult service. So I was the fellow on call when this consult came in, and so I went and saw the patient and advise them to go ahead and do the confirmatory testing.
Does anyone have other comments or questions, or had similar experiences in their consult work? I have another question separately that this case was maybe can think about the different ways that have been involved in, working with the transplant candidates in the inpatient setting and sometimes in the outpatient setting. There've been, occasional drug testing questions. Some of them have been compliance, just others to explain results, but none of them have been specifically, this is going to, a positive result will preclude them from being listed in quite this way. But Dr. Rivashevitz, have you in terms of the addiction work, you're involved in, helping treat patients, prepare them for transplant potentially, if they're given ultimatums, if you can get certain periods of sobriety. Can you comment a little bit about, some of your involvement with transplant candidates?
We're not involved with transplant candidates very much at all at our center. They have there's another consultant within the hospital that takes care of them. So I'm not quite sure what they're doing these days.
Well, it's been about a year ago now. I had a patient that was had primary sclerosing cholangitis and had been trying to had been on a transplant list for a while, but he'd struggled with opioids as well as marijuana and other drugs. And this is a young gentleman that they had given him and his family an ultimatum that if he wasn't able to stay sober, basically, he wouldn't be listed for transplants. And so he's basically kept in the hospital for about a month to give him some momentum. And our service was involved in getting him onto buprenorphine. He struggled with opioids and help coordinate a handoff to another program. He'd had some experience in an area treatment program in the past, kind of been in and out, and he basically was admitted to an inpatient setting for 3 months while he stayed away from substances and then sent to the facility in New York for the liver transplants, and unfortunately relapsed very quickly right after the surgery with the prescription opioids. But it was interesting to be involved with that. A lot of desperation from family members, parents, and the patient had limited insight. Does anybody have any other comments or questions regarding this case? Stephanie, you other last thoughts?
No, I think it was really a good case in the sense that, unfortunately, the gentleman did not wind up getting the transplant. He, like I said, had a lot of comorbidities and he died before he was able to get a liver. But I felt good about the fact that at least he didn't wind up being delisted for the wrong reason, and being denied a potential transplant because people wrongly thought that he was still using drugs.
Yeah, that was a pretty important contribution, otherwise. So, all right. Well, thank you. That was a great case. We're going to move along to case 2, which is switching gears a little bit. This is a interesting case involving a patient with opiate dependence. She's 32, has a history of polysubstance dependence, including opioids. Has been in treatment for about 12 months. Had been incarcerated for a year and a half prior to that for driving under the influence charges. She had been driving away from a drug purchase, had used in the car before pulling away, and ran a stop sign, T-boned somebody. She had just used heroin, but they found cocaine, THC, and some of the prescription drugs in her urine. The driver of the other vehicle was an elderly female who suffered numerous orthopedic injuries. She survived. Patient also suffered quite a few orthopedic injuries and now has chronic pain and also anxiety, PTSD from the MVA. She really changed her life, certainly. She had been doing well, not using any other drugs. She was taking buprenorphine, naloxone, and by all measures, it looked like she was taking it appropriately. She was engaging in group and a counselor. There was no med changes. And a monthly follow-up visit, I noticed that she had gabapentin in her urine the month prior, and she didn't report that any medications or changes. And I think people are a little surprised that it shows up. It's one of the things that we can test for in an opioid panel. And she kind of was anxious and said, "Oh yeah, that's my for my arthritis. I guess I forgot to say something about it, and she's taking 800 milligrams 4 times a day. She gets a little visibly anxious and restless as she starts to talk about it. And I said that's for a new med, that's quite a high dose. And I explained that I don't really like it, except in very rare certain situations for patients that are, opiate dependent. And she said, well, I know you don't like it, but it really helps my back, my hip, my shoulder, my anxiety, and I really don't crave it or anything. And we were going in a circle kind of discussing this, and so we agree that she comes back in 2 weeks to discuss this, and she had been on monthly visits. And I noticed she also had 2 unexcused appointments a week prior. So on the follow-up visit, we're going to discuss her gabapentin. And when I walk into the clinic to see her, she's like number 2 or number 3, and I can see that she's clearly upset. She's kind of got a flat affect. This is someone that's normally kind of good, charismatic, appreciative. She's withdrawn. When she comes into the appointment, she's looking at her phone. She's texting randomly, signs several times during the visit. I have to tell her to put away the phone. And so I knew something, was up. And she said, well, I guess I got kicked out of my halfway house. And I said, well, what happened? And she said, well, the gabapentins were a bad idea. I don't know what I was thinking. I can't believe I tried to do this again. I just talked myself into it. And I asked her to elaborate. And she said, well, I've always kind of had a problem with the gabapentins. I didn't realize you were testing for them. So I had capsules that I opened up and took the powder out, and I was going to put a different powder or filler in, but I didn't have any. So in a room search, my counselor found all the empty gel caps, and I got in trouble with that. And I didn't think that they were going to do a room search before I could actually refill them. So she describes now being off the gabapentin for 2 days. And she says she's not feeling right. I don't know if it's withdrawals or not. She was prescribed them by a provider. It had been taken about 3 to 4 weeks. The urine screen that was positive was right after she started apparently being prescribed, although it sounded like she was getting them from the friends, the streets, from other girls in the house intermittently as well. And so my question is what kind of experience do you have with gabapentin abuse, and what is the risk of gabapentin withdrawal? And then, is anybody able to comment a little bit about what the signs and symptoms are, and then how would you treat it? Again, go ahead and raise your hand if you have a comment or a question. About Ingrid, do you have a comment on this? Let me unmute you.
Sorry, I had to step away for a bit, so I kind of missed the part of it, so I'll have to pass on this one, I'm afraid.
Sure. Okay. Thank you. Dr. Bashevitz, what about you? Have you had similar cases?
I just wanted to clarify. She was taking them out of the capsule because she was snorting them or injecting them?
She had tried snorting them, but felt like it was a lot of powder. She wasn't injecting them. She had taken them out of the capsule so it would hide that she was binging on them and using more than she would. So she had described snorting them, but she said it was a lot of powder, and she didn't really like that. So it sounded like the powder just went in either a drink or she just kind of swallowed it down.
So how would taking them out of the capsule hide the fact that she was taking them?
So she could put another powder in the capsule, either another pill or another white powder. I didn't ask her to elaborate, but that was her intent.
Okay.
To fill the capsules back up with something that looked like gabapentin, so she'd have her own placebo or whatever else it was.
Interesting logic, yeah. So most of the time what we see is people who are using gabapentin to sort of boost the high that they get from either some kind of opiate, whether illicit or maybe even a medication-assisted treatment type opiate like buprenorphine or methadone, because people don't feel high so much on methadone or buprenorphine, but they feel that they can boost it in that way, similar to boosting it with benzodiazepine drugs. So I have met a few people, just a handful, who are taking gabapentin entirely out of control. They are just taking handfuls of it, kind of similar to this patient. And Actually, we haven't done a whole lot of treatment for them. The symptoms are similar to alcohol withdrawal because it goes to the GABA receptor, and they tend to be a little bit mild. Sometimes I've tried to taper them using gabapentin, but otherwise, often, when we catch people like this, we just say no more gabapentin, and they seem to do okay, most of them.
Yeah, that's great. Thank you for that description. And Emery Cox has your hand up. I'm going to unmute you. Go ahead.
Yeah, hey Al, it's Elena. So in our clinic, we've seen a fair number of people who are taking quite high doses of gabapentin, like 2 or 3 grams, 3 to 4 times a day. And it's similar to what was just described when people stop taking it with the withdrawal symptoms. I generally will just taper people off of the gabapentin, and I've had some pretty fair success with that. I've had one person in particular who had been taking 3 grams 4 times a day. When we got him down to, he was doing all right until we got him to 600 TID, and then when we dropped him to 300 TID, it was intensely destabilizing. It was really interesting. He just developed really severe withdrawal, and really more the mood symptoms were what was bothering him. So we've actually maintained him on 600 TID. He's one of the few people who I do have on gabapentin. But most everyone else I've been able to just do a several-week taper, and they've done really well.
Good, thank you. That's interesting that you had this problem when you got down to the 600 from the higher doses that he tolerated, the taper to that point. Anybody have any other experience with gabapentin withdrawal? What about there's the Kentucky poison control? I know that there was I think Kentucky was one of the first states to add it to the prescription monitoring program or equivalent to essentially restrict it, I believe. Is you able to comment? Someone from Kentucky able to comment on that? Does anybody live in a state where it is showing up on the prescription monitoring program equivalent or otherwise restricted, scheduled? All right, well, I'm going to move ahead and make some comments. So this, there's a lot of data over the last several years kind of describing the increasing rates of gabapentin abuse and, just commentaries on what is the risk of abuse, dependence, withdrawal, and which is pretty low in general in the general population. But when you get into individuals with experience using substances, you start to see dramatic increases. Like one review article found 22% in drug treatment programs had criteria to meet gabapentin abuse, dependence, or withdrawal. And in opiate treatment programs, I've seen data that suggests it's even higher, up to a third potentially, and even higher in some areas in certain cities in the U.S. Was at the ACAM conference a couple weeks ago, and there's several posters describing different cocktails of pharmaceutical agents that people use to potentiate their usually methadone or buprenorphine or illicit opioids, and gabapentin is often one of them, along with others. And it's a growing trend, it seems, to use prescribed medications to kind of potentiate opioids or just for their intoxicating purposes, along with buprenorphine or methadone. So this was one interesting article. You can take a look at the reference in the slides if interested. One of the first case reports of withdrawal that I could find was in 2007. It was an individual using up to 7,200 milligrams a day, was prescribed 4,800 milligrams and 1,200 milligram increments. That should be QID instead of TID. When she could no longer obtain any prescriptions and pharmacists refused to give her gabapentin, she developed typical withdrawal symptoms, including trembling, sweating, excitation, pallor, and exophthalmia. And that's from the case report in the article. And another reference regarding withdrawal was in a 57-year-old female alcohol dependent admitted to the hospital with alcohol intoxication and then some complications from the alcohol abuse and dependence, was on a variety of medications, including gabapentin. On the third day of hospitalization, she started to get restless, disoriented, confused, agitated. She's anxious, and it was thought that she was suffering from alcohol withdrawal. She was treated with benzodiazepines, but they didn't have any improvement in symptoms. And the fourth and fifth day, she was getting worse, and they restarted her gabapentin, and she had a fairly rapid improvement. Now, there may be some problems with this. Gabapentin can be used to treat alcohol withdrawal as well. In fact, there's studies showing it's pretty effective for mild or moderate withdrawal, so I'm not sure that this is just gabapentin withdrawal, but it's interesting. It's a lot of patients that I've seen taking high doses only take it intermittently. They run out of their prescriptions, and so they're more binging on them and don't really take it daily. The first case of withdrawal that I had seen was a gentleman that had really severe cocaine dependence and was taking it each night to come down from the cocaine, really high doses, and then throughout the day as well. And so he had cocaine binges, and then throughout the day the gabapentin, and he had a complication from the cocaine use and went into withdrawal from the gabapentin in the hospital. He was taking heroic amounts of gabapentin. And I've seen it a couple of other times, and mostly described by patients saying they feel restless, and if they really are using a lot of it, they have to taper, and they feel miserable, and that's if they're taking it regularly. In a couple of the references, it talked about delirium and symptoms that really didn't respond to benzodiazepines or other GABAergic agents, but would respond to re-administration of the gabapentin, suggesting that there's only partial cross-tolerance with gabapentin and other GABAergic agents. Gabapentin's kind of indirectly GABAergic. In one case, there was some abnormal movements, and I've seen this in a couple of patients, although we just recently had a case in the hospital was not gabapentin, is pregabalin. The patient had myoclonus and tremors from accumulation and renal failure, and then with holding her medication, she was just off a little bit, and reinstarting it, she really calmed down. She had kind of restlessness and not necessarily akathisia, but just some abnormal movements restarting. She seemed to be doing better on restarting the pregabalin in that case. So it seems like in reviewing the literature, there's a variety of movement problems, dysregulation, mood, anxiety, panic, other kind of abnormalities, and then some autonomic hyperactivity, things similar to alcohol withdrawal with tremors, and so that's what I'd be looking for. If the patient was only on for a couple of weeks and only intermittently using, I would probably be mostly subclinical and more craving and just general anxiety and maybe a little insomnia instead of really overt symptoms. But, our patient didn't have obvious withdrawal symptoms. Looking at her, I think she was more frustrated that she lost her housing and is, oh, shoot, what am I going to do now with this? Gabapentin is structurally similar to GABA. It's one of the GABAergic agents called the gabapentinoids. They're analogs of GABA in a sense, along with pregabalin, baclofen, and phenibut. It acts as an inhibitor at the alpha-2 delta subunit to the voltage-gated calcium channel. It has anticonvulsant, anxiolytic, and sedative effects. It's interesting absorption limitations I don't really see necessarily clinically. There's variations in absorption and rates of absorption by dose, and then also by other effective GI motility. If it's slow or stopped or fast, the absorption will change. It's absorbed by the LAT1 receptor, which is saturable apparently. So higher doses, you really should reach a ceiling effect. This also is responsible for getting it across the blood-brain barrier. So at higher doses, you should get ceiling effect, which I remember as a resident hearing it being touted as safe. You can really push the dose. People won't have, side effects because it's just not going to be absorbed. You can, go higher and higher and just don't worry about safety. And that's not really the case. But I clearly see as people raise the dose, this myoclonic encephalopathy, falls, tremors, sedation, and taking, it's literally almost a daily occurrence that we're taking care of patients that have gabapentin or gabapentin and baclofen together now, complications often with opioids or other drugs. Oh, I went back. So back to our case. Our patient is given clonidine, and because of kind of chronic anxiety, added Buspar to her SSRI, and she continues on the buprenorphine naloxone. She's seen daily after this because there's concern of discharge from her halfway house while she gets stabilized in another living situation, and the counselor doesn't think that she's in withdrawal, nor does the other providers. A couple of times she admits to purchasing Gabbies by the bus terminal. Apparently there's a guy just sitting there selling them, and she has to walk by him every day. And she, after a discharge from the halfway house, she's is subsequently admitted to a second halfway house. She's admitted and put on a contract about the use, and she goes a couple months without using the gabapentin, but she's really frustrated, and her visits are interesting. She is at turns very optimistic and happy that she's able to stay away from him, and then really frustrated and resentful because she sees half the girls in the house on gabapentin, some on that and baclofen and bupropion, and she can see that they're clearly abusing him, and she thinks, well, why can't I? Why can't I? She really likes the gabapentin. And whether it was the gabapentin, what it was happening to the buprenorphine, it's not clear. That certainly is probably part of it. But she said it's just rampant in the houses, and she says specifically, there's girls nodding out all over the place. And when she sees that, she can kind of recognize these little jerks and twitches and knows that they're using the gabapentin. And she had almost an altercation with another girl in the house who she was asked to go get prescriptions again for gabapentin. She said, well, if you're tested for it, it's not going to show up. You don't need to take it then. You can give it to me or I'll buy it from you. And she refused to do that and was threatened violence. And it just was kind of a big fiasco. So it's really a huge deal, it seems, causing a lot of problems in addiction treatment. And I don't think we've really reconciled on where it belongs and how to use it and how to work with patients that people are put on it all over the place. They come back from a treatment program or put back on gabapentin, go to the ED or put back on gabapentin. The last 3 insurance restrictions that I've been involved with had to do with repeatedly filling gabapentin from multiple prescribers. So you're nodding, Gloria, of any more comments or?
Oh, well, I was just thinking of one other pattern that I seem to see. I just saw a guy like this morning. He was on gabapentin for diabetic neuropathy from his PCP, and I guess it didn't provide enough relief. So the PCP started pregabalin, but the intent was to do a cross taper, and the guy is sort of begging for the ability to take pregabalin in the morning and gabapentin at night. That's his preferred method of doing this. So, he is legitimately diabetic. He has a lot of medical problems, but you could see how the temptation can get.
Yeah, that's great. So there's been a couple of comments. Let me read from some of the comments. We actually I missed some of these from the previous, I'm going to go back to them after the case from the previous discussion, but I'm going to, see street use of Johnny's literature from Bill Walson, the host and presenter. We have Emery saying pregabalin but not gabapentin shows up on the Georgia PDMP. Yeah, that's pregabalin shows up on New York I-Stop, but not gabapentin. Another from Phil Walson is gabapentin use abuse and the U.S. opiate epidemic, the case for reclassification as a controlled substance, and the need for pharmacovigilance. So it's a reference sent out. That's great. Thank you. Yeah, there's a growing number of literature related to gabapentin abuse, and I increasingly I've seen in a couple of our patients, all 3, gabapentin, baclofen, and pregabalin, and for a couple of years, it wasn't really seen as much baclofen in the opioid use disorder, but now it seems people are recognizing that that may have some similar effects to gabapentin and pregabalin, and it doesn't help that it's sometimes used off-label for cocaine craving in these patients, and they kind of hear about it. So, and then occasionally phenibut came up earlier today in a conversation I was having. Who a guy knew about it, but he said, no, I haven't gotten that. I'm not going to go back to the designer drugs. So, I think any other comments or questions regarding the gabapentin? Ingrid, you've got your hand up. Let me unmute.
Yeah. Can you hear me?
Go ahead. Yep, you're good.
Yeah. So this isn't specifically about gabapentin, but the situation that you have up on the screen that she described, I see quite frequently. Our clinic is downtown, and many patients will describe the fact that there's temptation all around. There's a gauntlet that they have to go by to get from the rapid transit train to the clinic. In fact, a number of patients have said that dealers will hang out around the corner from the clinic, so as soon as they finish, they're exposed to temptation. And I've had women say that they're staying at the YWCA, and there it is again that everybody's using. So I'm not sure how to counsel these people, because I mean, once they leave your clinic, you can't really go and shake your finger at all these dealers that are hanging out there. I'm not sure I would recognize them even, but does anybody have any thoughts about that? Because it's a real issue for our patients.
Well, thoughts about working with the triggers and exposure to other use. Is that the question, Ingrid?
The question is the fact that they physically have to, they're exposed as they're leaving your clinic, as they're coming to the clinic, because these dealers are around, other people are using, they offer, and that's often the difficult part, right? If it's in your, if you stay away from it, many people can deal with the temptation, but if it's in their face, it becomes so much more difficult. And I hear their frustration. I heard her frustration about that constant exposure and the fact that it triggers temptation and it triggers craving.
Yeah, no, that's great. Half the time I'm wondering how on earth somebody that's successful is even remotely successful. When they have someone in the same apartment selling, or their spouse is using, or two people in the apartment are using, or they open their door and it's right in front of their door, or right down in front of the street. I mean, it's unfortunate, but several of the halfway houses in Rochester are in areas right in the epicenter of the drug markets. And, you hear, the patient saying is, I could see where I bought heroin right out from the bedroom window, and you're going into a halfway house, which is really frustrating. But there's other areas, like we have spouse, the smoking. We had a clinic yesterday, and I've been worried about a gentleman's ability to quit and then stay quit with smoking. He was waiting to pick up Chantix, Phenyclean, when it was covered. He was able to pick it up, but his significant other was a really heavy smoker. And so I thought, well, he's going to get off of it potentially if it works and then stay away, but eventually he's going to go right back. And he surprised me, that he was optimistic. He was working, it's coming down, but then he said, his significant other was also able to go get a prescription for Chantix, so they were doing it together. So, but yeah, I see, an alcoholic. We had a gentleman was a chronic alcoholic, pretty severe withdrawal in and out of DTs, atrial fibrillation, and his wife was a heavy drinker and didn't think she had a problem, and he could go a couple of months, and then, she would be drinking around him, and he'd pick right back up, and I think I see this, all over the place. So, let's move on to the next case. We've got a couple of, the last two are a little bit quicker. Case 3 is the gentleman, history of alcohol dependence, 32 years old. Dad is picking him up a couple of times a week to get to work because he wants to check in on him, concerned he's gone back to drinking. He had come in on a Monday and wasn't able to wake him first at the door, and then went inside, and he says, I found him snoring into his pillow, and I thought I couldn't get him up. I thought he just resumed drinking. He had that kind of heavy snore, and was flushed. He just looked like he had been up all night drinking, so I let him sleep it off. Now, his roommate, who had been treated in the area hospital the day prior for an overdose of opiates, returns and finds him unresponsive, and he's blue. He's got tenuous respirations, and his roommate calls 911. And EMS finds this gentleman hypoxic, cyanotic, stats are in the 50s. He's given naloxone, and there's some debate over exactly the timing of events, but it sounded like he got real agitated, and the EMS providers had to give him some sedation to get him calm and into the ambulance and transported. He's a very big guy, bodybuilder, anabolic agents. They gave him some midazolam, haloperidol, and ketamine. In the emergency department, he's on a non-rebreather. He's got epistaxis, evident from the nares. He's intermittently responsive to name, but only briefly closes his eyes and is back kind of breathing deeply and groaning. He had gotten a second dose of naloxone prior to us seeing him, and he had transient awakening, but didn't really clear his mental status. He's found to have a pretty swollen left upper extremity. It's red, it's tense, and he has an urgent evaluation by orthopedic surgery, and he's diagnosed with compartment syndrome, and he undergoes a fasciotomy. The patient's alcohol level is negative. His urine drug screen's positive for cocaine and benzos. He's got a marked leukocytosis. His CK is in the 80,000s. His bicarb is low. His creatinine's a little bit up. He's not known to use heroin. Occasional use of cocaine, long history of alcohol dependence. And we were consulted to try and help understand the overdose and to provide recommendations. So this initial day, initially we'd seen him, and he's intubated to go to surgery to get the fasciotomy, and we'd given some recommendations in general for this overdose, supportive care, and the patient is admitted to the ICU. On hospital day 2, he's intubated, and he's only on propofol, and he's only minimally responsive on propofol. He's on pretty good dose, 45 micrograms per kilogram per minute, nothing else. And he responds a little bit when the dose is lowered, but he's not agitated, and he's not appearing uncomfortable. He's not gotten any opioids either in surgery or postoperatively. The ICU team is asking about our recommendations, which we haven't gotten good collaborative information other than, he had used heroin, the roommate had an overdose. He didn't have any obvious stigmata of IV drug use, but apparently he had injected heroin and cocaine the prior to the episode. And I suggested we'll consider buprenorphine if we can get more history. We can always add other opioids on top of it. Otherwise, he's going to have pain from his fasciotomy. You could go to fentanyl. If he's soaking that up like a sponge, you probably suggest that he's more tolerant, and we can go back to buprenorphine. The team decided to not do buprenorphine initially. It seems to me that they thought this was kind of an all or none thing, that they wouldn't be able to back off of it initially. There was, I think, some miscommunication. And put him on fentanyl, 100 micrograms per hour. And the second day when I saw him, he was on fentanyl that had been increased to 125 per hour, propofol to 50, started Dex, and he's really struggling to stay calm now. He's waking up, and his parents have both come, and also a friend who runs a program in our area. Rock Recovery Fitness is a big fitness advocate, and she confirms that he had been a fairly heavy kratom user for a while, for years, and she knows that he's been using anabolic agents. She says he's only been using the heroin intermittently recently, more than once, but intermittently, in the cocaine, but he had a pretty substantial cocaine use history in the past. So I'm wondering what thoughts about this patient in buprenorphine in the ICU for pain control. If so, how would you initiate it? Any thoughts or comments or questions about this gentleman's care?
I have a question about his buprenorphine suggestion.
Sure, go ahead.
How effective is buprenorphine for acute pain of this sort? I thought it was okay to use for chronic pain, but I can't think that it would be terribly successful for acute postoperative orthopedic type pain.
That's a great question. So, and I often think of the buprenorphine as not just the sole agent. It just gives us a better base to then choose other options. And if this gentleman had turned out to be dependent and then kind of going in much more tolerant, that's going to much more easily take care of kind of his dependence, and we can add full agonists on top without, and then when we're done with it, there's going to be a buprenorphine there, and we can transition much more simply. So, but I see it very effective too, and I think that this gentleman, from what I understood, he'd been off of kratom for a little bit, but he had been a substantial user until recently, and then with re-exposure to the heroin, I was expecting that with the fentanyl, he's going to very quickly be escalating the doses, and it'll look like he's just, again, opioid dependent. So, I thought it would be a pretty good choice. It's a pretty potent opioid. It's used in the hospital as Buprenex at 150 to 300 micrograms for moderate to severe pain for IV use. And there's been a number of cases, some of them we presented at this conference, in which patients were on full agonists at pretty good doses and just not getting good pain relief, and then they were switched on to buprenorphine, and they said they felt much better. I think that from a combination of things, but certainly it would be a dose it, reassess, and split appropriately, titrate up, and then if needed, add full agonist, multimodal pain control. He couldn't tolerate an NSAID because of his kidneys, but multiple different agents for his fasciotomy.
So what doses of buprenorphine do you find are effective for this kind of a situation?
Well, it depends on the tolerance and the dependence of the individual. If most of the patients, it turns out that we're helping out with pain and are actually fully dependent, and usually we'll get the patient on 8 milligrams, split either 3 times a day or 4 milligrams 4 times a day, and then add other opioid agonists for the immediate kind of perioperative period, a couple of days at 2 to 3 times standard doses if the buprenorphine alone isn't effective. A patient with like a sternotomy, if they came valve replacement, would come out on probably a PCA with pretty high doses of hydromorphone on top of split doses of buprenorphine. We had a patient recently that had an amputation that after the epidural wore off or was stopped, was on a PCA with the buprenorphine 3 times a day, and I don't recall exactly what the PCA dosing was. I think it was a half milligram every 10 or 15 minutes, and then he transitioned to oxycodone 20 to 30 milligrams every 4 hours. So 2 to 3 times your standard doses of opioids, and they get good analgesic effect if you need to on top of the buprenorphine, and then it's fairly easy to go down from there after this acute pain resolves. So is buprenorphine at 2 or 4 stronger than fentanyl at 100 or 125 micrograms? Probably. I don't see, if somebody's fully dependent, I don't see the 100 and 125 micrograms of fentanyl keeping them very well out of withdrawal. Usually you've got to go more. So, if it's not even enough to keep them out of withdrawal, it's probably not going to be enough for pain. This gentleman wasn't in withdrawal, so I don't know. This would have been dose and reassess. Those are good questions and comments. I'll send around. I've got a really good resource on perioperative management of patients on opioid agonist therapy that gets into good kind of nuts and bolts of buprenorphine analgesia and how to dose it and some strategies, as well as for methadone too. Any other questions or thoughts about this? Jeff Brent always asks if I can remind any of you that are participating in Toxic, there is a option to enter cases related to buprenorphine or addiction in the kind of a sub-registry. It's not a full sub-registry, but in the Toxic registry to get more information on how we're managing patients like this. All right, I don't see any other hands up right now. Please, again, you can chat as well. That case is ongoing, and the most recent recommendations were because he's taking the fentanyl or requiring higher and higher doses of fentanyl and propofol and dex to try and overnight get him transitioned off of the fentanyl onto buprenorphine and to help get him extubated without the full agonist infusion continuing. So we have to check up this afternoon and see how that went. He was recommendations to use higher doses of propofol, higher doses of dex, turn off the fentanyl at midnight, 6 a.m., 2 milligram dose of buprenorphine, and titrate up from there. And it sounds like they did it, and it worked just fine. So good. 6 hours off, and they're extubating him imminently. All right, our last case is an interesting, a quick case that was challenged to me. I had a very pleasant gentleman, 64-year-old African-American, long history of opioid use disorder, intranasal heroin for about 20 years, presented to the clinic after being started on buprenorphine naloxone in a detox setting. He reports he's also drinking a little, so they detoxed me from that too. He was on buprenorphine naloxone 8/2, 1 sublingual twice a day. And at the first visit, he reports he's doing well, no use, he's a little anxious. He can't remember his medication list, but he says there's a lot of them. His urine test results from earlier in the week show positive for buprenorphine metabolites, diazepam metabolites, and phenobarbital. And he says, I don't know what that is. They must have given that to me in detox, I think. And I said, okay, let's often use if benzodiazepines are not, or sometimes concomitantly. I can think of a couple programs in our area where phenobarbital is used both for alcohol or benzo detox. And so this is not too atypical. And over about a 3-week, 4-week period, we had kind of a drop in his phenobarbital concentrations. He's checked with urine about once a week, and they were getting confirmatory tests to quantify the kind of defaults for the lab we use. And then it spiked up and then kind of plateaued for now the 3rd month and the 4th month and into the 4th month. And the gentleman has actually his name as well as middle initial name, and there were some tests that were under the other one. So this actually goes on beyond 4 months. There's some results in another report that I don't have included here. And as it got into the 2nd month, I kind of became suspicious, saying, where's the phenobarbital coming from? And he had no idea what I was talking about. No idea. The next visit, where's the phenobarbital coming from? It's really dangerous to be mixing this with, buprenorphine, and, I'm concerned. And if you don't know where it's coming from, we really need to figure this out. So I'm wondering if anybody has any thoughts on this persistently positive phenobarbital level in this gentleman on buprenorphine maintenance. Where might he be getting phenobarbital from? He swears it's not in his house. He lives with a significant other. He has a nurse help out with a med minder. I don't have his complete list of meds, but none of them are phenobarbital. Any thoughts? Has anyone seen individuals get phenobarbital? Ingrid, do you have your hand up again, or?
Yeah, I do.
Good.
I was wondering whether he might be taking something like Furanol, because so there are some combination products out there that do have barbiturate in them. But that's the only thing I could think of.
Yeah, that's a great question. And Furanol or Fioricet with butalbital, but this was not just a positive barb assay. That was reported, and then we were confirming phenobarbital at certain levels. So it wasn't just a positive barbiturate. But you're right, that's probably the most common barbiturate that I see between butalbital and phenobarbital if somebody's getting detox. Josh King, you've got your hand up. Let me unmute you.
Hey, sorry, this is actually Jimmy, the fellow here. So I believe primidone is metabolized to phenobarb, and I question whether he's taking that.
That's a great thought. Yes, it is metabolized to phenobarbital. I think it's used for tremor, central tremor, or maybe not essential tremor, but more severe.
Yeah, or
maybe
it's
well.
phenobarbitaloma.
That's great. No, I have to say that I did think I asked him about, do you take any meds for tremors or primidone? And I had one case a couple of years ago where a patient was taking their dog's phenobarbital. and I asked if his pet had any, if he had a pet, and did his pet have seizures, and he denied that. And so what would you do? What would you do in a case like this? Are you concerned with the buprenorphine and phenobarbital? I bring this up because we talk about benzodiazepines and buprenorphine, and this is phenobarbital and buprenorphine. And I'm fairly certain that he's getting it, from somewhere, just knows where he's getting it, just doesn't want to tell me. Lori, do you have thoughts? What would you do if this is a gentleman in MAT clinic?
Well, probably just consider it a treatment issue, and assuming that he is alert and oriented and can talk reasonably well, it doesn't seem to be cognitively impaired from this. So I would keep assessing that and make it into a treatment issue where, we're doing urine screens, we're showing him the urine screens, consider inpatient treatment maybe. That would be another way to get at this, inpatient rehab. And that's about all I can think of with this guy. Also, it's still puzzling where he's getting it. We don't see too much phenobarb use around here, and I'm not sure it's popular in the rest of the country either.
Yeah, that's good. Now, that was one of the problems, is he's always a bit wobbly and kind of slow balance coordination issues, and he's a big guy, and I kept on envisioning, Zach, why did you keep this guy on buprenorphine? You knew he was getting phenobarbital from somebody. He walked out in front of a car yesterday and got hit. I don't know, which didn't happen, but I'm just envisioning this. So it took I'm going to refer you to inpatient so we can get you out of your environment and really figure out where this came. That didn't do it. There was some delays into potentially doing that. But then I had said, well, you know what, I'm going to taper your buprenorphine a bit because I'm really worried we're going to go down a little bit lower. And as soon as I did that, the phenobarbital started to drop and disappeared. And it turned out that he was getting it from his wife, or he called it his wife, but it was a significant other who had a seizure disorder who didn't really like to take it, and he liked to take the phenobarbital. He was exposed to it in detox, and he liked the phenobarbital. So we found it wasn't quite as dramatic as the dog or the cat's phenobarbital, but pulling open kind of concentrations over time, he had quite a few up to that point where it was up and down, and so it was clearly not just a dropping level from a detox. Before he admitted that he had gotten it from his wife, he tried to have me talk to the nurse filling it to ensure me that there was no phenobarb he was taking. He was very concrete, and if you see that there's none in these 2 bottles, I must not be taking it then. So a month after he comes off of the phenobarbital, and I get a call from his primary care doc saying that he's asking about gabapentin for nerve pain, and he's wondering what I think about gabapentin, and so we're going to end the case on that unless anyone has any other questions or comments. We're at just a little after 2:15. We've got a few minutes here if people are willing or interested to take a couple other questions or comments. Emery, go ahead. Let's see, unmute you. Go ahead.
Hey, all. I actually have an entirely unrelated situation that I wanted to get some folks' thoughts on. I got a call from one of our anesthesiologists who runs our acute pain service, and they have a woman coming in next week for a bilateral radical mastectomy with dissection into the pectoral muscles and then flaps, and long story short, big long surgery. She's been taking oral naltrexone, 50 milligrams a day, for about a year for opioid and alcohol use disorders. And so their question was, what should we do about this? And I just said, go ahead and stop it 3 days ahead of time, and she should be good to go. For some reason, the acute pain service is really uncomfortable with that plan. So I was curious if anyone else had run into a similar situation, or if you have alternative recommendations, or just interested in everyone else's thoughts.
Sure. Thank you, Elena. That's a great question. Does anybody have any comments on Elena's question? How long before surgery do you need to stop that's oral naltrexone?
Yeah, it's oral.
I don't see any other hands up, but I think that you're fine with stopping it 3 days before this, before the surgery. They should be able to get, effective analgesia with, with whatever opioids they're using. Why were they hesitant in that? Did they want her off longer, or?
No, what they told me was that they are worried that, taking her off of it is going to increase her risk of relapse, and they're worried that she's going to, go out and overdose in the 3 days that she's off this med. So I think they have somewhat of a not complete understanding of how these medications work, because they were asking to start her on buprenorphine as a bridge to her surgery, which I said really wasn't indicated in this case. So I just wanted to make sure I wasn't missing anything.
No, I don't think so. I think that's interesting. That's a lot of misunderstanding sometimes about, these medications and starting and stopping. I've had for buprenorphine some really ridiculous, odd kind of recommendations. Stop the dual product, only use the mono product, and patients are counseled kind of with really kind of funny recommendations from time. So we're at just after 2:20, and we've gone over a little bit, so I think we're going to call it an afternoon. I want to thank you all for joining, and Stephanie, thank you for presenting the first case. That was great. If anyone has any additional cases or would like to present, please send me an email. This is recorded, should be up on the ACMT website later on. And again, thank you all for joining. We'll be back in June.